Welcome to EM Pulse, bringing research and expert opinion to the bedside.
We're your hosts, Sarah Medeiros
and Julia Magaña.
Welcome back to EM Pulse.
You know, Sarah, sometimes I joke that the outpatient clinic sets up a recording that says, "Welcome to our clinic. Please go directly to the emergency department," when a parent calls in for advice. But of course, I know that that's not true, and there is much more to it. I also recognize there's probably significant variation between practices based on resources and locations, to say the least.
Yeah, but I feel that too sometimes. So to help us understand the outpatient perspective, we've invited two of our UC Davis colleagues to be here with us today. I'd like to ask you guys to introduce yourself.
I'm Lena Vanderlist. I'm a general pediatrician, so work with kids really from birth to 21 sometimes. I don't know if you would call it kids anymore. And I have the privilege of working both in a community clinic as well as a federally qualified health center. So kind of get to take care of kids with lots of different insurance types.
I'm Olivia Campa. I'm an assistant clinical professor at UC Davis Health in the Department of Internal Medicine. So I'm in the Division of General Internal Medicine, which means that I do both inpatient and outpatient medicine, which is nice because I get a bit of the perspective from an adult side of, I call it the continuum of care, which is really like all the outpatient issues, and then into the inpatient side through the emergency room, sometimes into the ICU. And so I think that very much informs my care on the outpatient side.
I feel like there's not many people who do that in the academic world anymore, so that is really a unique perspective.
Yeah, there was a shift a few years ago now where people decided, okay, you can only do ambulatory medicine or hospital-based medicine, but some people held on to general internists who do both, but it's definitely not the norm. And I think we scratch and claw to hold on to our roles both in the inpatient and outpatient setting. But for me personally, in my practice, I find it to be incredibly helpful.
I could definitely see that being helpful. All right, guys, walk us through, help me understand what happens. There's not really a recorded voice, right? When a patient calls in for medical advice, tell me who answers that phone call? How do they get triaged?
It's funny when you tell that story because really my heart sinks sometimes when I log onto my computer in the morning and I see that note of one of my patients who I feel I've educated well about when they should utilize that emergency room has gone in, for a fever or an ear infection or something I could have treated them in the morning for. I'm always like, oh, what can I do better to make sure, no offense, not as much for providers, but for my patients, like, oh my God, they probably sat there for 8 hours waiting for their antibiotic for an ear infection that I could have just seen them in the morning. So to answer your question, when a patient calls in for medical advice, it's different everywhere. So I have a really good friend from medical school who works in a rural setting, and she really, in the after hours, like after the clinic is closed, she answers those calls or she splits that time with like 2 other pediatricians in her community, and she is the one that's talking to the parents. Here at UC Davis, they will talk to a registered nurse, usually if it's during clinic hours. So Monday through Friday, 8 to 6, they're going to talk to a nurse, and she will help look at their symptoms and probably use a pathway or an algorithm to decide which advice to get, or if she needs to reach out to the medical doctor for more information. After hours at UC Davis, so in the evenings or the weekends, that's going to go to an outsourced nurse advice line. So that will be a little bit different. They'll still use an algorithm, but they don't have that option unless it's, a really big deal. They're usually not going to call the on-call physician, and they're just going to triage directly to the emergency room if that is what the algorithm spits out.
Yeah, very similar on the adult side. Many places, academic centers, mainly because academic centers tend to have more resources, are moving towards these centralized administrative hubs where all of the people who answer the phone are in one place, all of the people who triage are in one place. I think the benefit of that is you don't have duplication of services where you have each clinic that has all of this administrative support that is hard to right size for the clinic space. The downside to that is the protocolization of healthcare has become even more, right? I mean, nurse triage, they're amazing at what they do, and we are always grateful for them. And sometimes the training is less than perfect. And so I think that there is this generalization that patients have when they call the clinic. They don't necessarily know who they're talking to.
Yeah.
They could be talking to the front desk person that has no higher level healthcare training, or they could be talking to a nurse, or they could be talking to a doctor. But for them, they lump it all together. And sometimes people call in crisis and everyone freaks out and says, go to the emergency room, right? Instead of, as a primary care doctor, I know my patients very well. And the pleasure of being an adult internist is that I have highly complicated patients who, if they call me in a few seconds, I can figure out what the highest yield triage zone is for them. But they're sometimes speaking to a complete stranger who doesn't know them, and they sound very scary. And so I think that sometimes patients inadvertently do get sent to the emergency room through phone triage, even though we try to build systems where we're optimizing how we deliver care.
So it's really about optimizing that time of the physician and the healthcare provider and centralizing those and making them more standardized. Is it like they actually have a list of questions that they have to ask, and then if yes, then that, and no, then that, and they go through? Or do they engage brain and go on their own pathway and ask questions, therefore making it even more variable, let's be real, right, as to what the outcomes are?
Yeah, so there are standardized triage protocols, and they follow the if, then that. Yeah. But the nurse triage, they are trained nurses who have the ability to make clinical decisions. And so for them, they do go off the algorithm. So I think where it becomes difficult, it's like when we think about clinical trials, right? The patients we see in the emergency room are not necessarily built for the algorithm.
Yeah.
So I think that's where it becomes difficult, is the if yes, then this doesn't apply directly to our patient population. And then when you layer complexity of illness, socioeconomic status, how people communicate in crisis, escalation of emotions, right? It can get really complicated really quickly. And I think on the phone, there's limitations to that. I think at Davis, we have this great system in which we can say, okay, well, why don't you call the telehealth provider and you can see them and speak to them, and that's staffed by the emergency room docs. And so they're very familiar with who should go to the emergency room. Or we have a system where we can send a doctor to someone's house and they can see them, because I do have patients where they're like, I can't leave my home because my oxygen only lasts for 45 minutes and the ride to Davis is an hour and a half. And I'm like, okay, well, now we can send someone to evaluate them in their home. So as systems can develop savvier ways to meet people where they are, we can keep people out of the emergency room and out of the hospital, which definitely drives down cost, but also demands that systems develop savvier mechanisms to see people where they are.
Right.
So where do these protocols come from? Is there some kind of evidence-based development that goes on?
So at least the after hours program that we use and these algorithms, it's called the Schmidt-Thompson clinical content. And they at least say that 95% of after hours and managed care call centers in North America use these algorithms. And when I was looking into it a little bit, it said that they are all at least reviewed and updated annually by a review panel that is comprised of nurses, specialty nurses, call center, medical staff, PCPs, emergency medicine physicians, and subspecialists. That's all it really told me. So, I do think that they tend to update the guidelines, at least when I see them come through. They seem reasonable for the level of expertise of the person. That being said, they're not looking at the comorbid conditions. They're not looking at the medications that the person is on, anything else that may go into it. So you hear worst headache of your life. Is it appropriate that maybe they get sent to the ER not knowing that like this kid also suffers from complex migraines or something like that? But it looks like there is a standard and a review process for them.
So I know you guys are extremely busy in your clinic visits. When you are having these discussions during the visit or maybe over the phone, how do you actually talk to your patients about when it is appropriate to return to the emergency room?
I tend to be a very direct communicator. So I guess the other thing I should disclose is that I tend to send less people to the emergency room than some of my colleagues. And the reason is because I believe very strongly in our outpatient infrastructure. And I think I also do a fair amount of operations. So have the sense of what the resources are, how long it takes to get to places. And I'm not scared to call anyone. So I will look up the on-call ENT person and I'll call them. And sometimes they'll say, send them to the emergency room. And I'll say, why? And so I do think, again, we work in an academic center. We're lucky we have all of the resources at our fingertips. That being said, when you're working with patients, you do have to get them on board, right? Like I can say, this is my recommendation, but they're not necessarily going to follow it for various reasons. And some of the reasons are incredibly justifiable. Like they have small kids at home that they need to care for, and there's no one else to care for them. So how are they supposed to spend a week in the hospital? So I think part of it is as you're meeting people and getting to know them, assessing what their lived experience is, how important do you feel it is for them to be in a certain care setting, and then having knowledge about what the available options are. Because if people say no, and there's nothing you can do to force them to do anything. So I think assessing that and doing that very quickly becomes important. And then I also think just getting a sense from the patient about escalation of care and how knowledgeable are they around the things that would require them to escalate their care. And so I think that's probably where I tend to lean into. And again, like if it's my own patient, I know them very well. And so that's very easy. But for patients I don't know well, if I'm in urgent care, then I kind of take into account all those things.
For me, I mean, of course, there's that initial gut check when you walk into your exam room. In pediatrics, we take care of a lot of respiratory illness. So, like, sometimes I will walk in and I'll see, oh, this kid is really working hard to breathe. Or, like, I look at their oxygen saturation and I think, okay, well, this is probably not looking good. I think about what resources I have in my own clinic. So, no offense, again, I never like to send any of my patients to the ER if they don't have to be there because of how long they're going to have to wait. I've been there as a mom and I know it's not great. So I'd rather bring them back the next day. I'd rather have them wait, if I can, for like 3 hours in my office, seeing if an albuterol nebulizer like turns them around or a dose of Decadron or something like that. Being mindful that I do only have 3 exam rooms that I'm working with. So if I'm taking up one with a kid that's going to be there for 3 hours, that puts me behind too. So we have things like albuterol. We have IM ceftriaxone. We have some steroids, Zofran, antipyretics. But our resources of what we give medication-wise are limited. So I have to be mindful of that. I have to think about, do they need urgent imaging? So if a kid, I'm worried about appendicitis, but I'm like, maybe it's just like some gas passing or something. Sometimes I can get a same-day ultrasound depending on what setting I'm in. And sometimes it's a Friday afternoon, and that's not going to happen. And so I have to think about all of that. I have to think about how urgently they need to see a specialist. So recently I had a child that had an HSV outbreak around her eye, and she needed to see ophthalmology. So I started her on an antiviral, and I was able to get on the phone and ask the subspecialist to get her in the morning. And he was able to, but in another clinic I work at, that never would have been the case. And so in my patients who are on Medicaid or have insurance where I don't have that relationship with the ophthalmologist that accept their insurance, right? I would have sent her to the emergency room.
Yeah, it makes a lot of sense. Lena, you have parents instead of patients as primary decision makers for a big part. How do you approach those parents when you're making those decisions?
I tend to have just an open and honest conversation with them. I'm a very much like talk out loud person. So like, these are the things I'm seeing that make me uncomfortable in the primary care setting. Like, look at these retractions. You see your kid grunting or the nostrils flaring out. I talk about the things I'm worried about. And I think this is always something that's hard too, because inadvertently, sometimes we can plant expectations into our patients' heads about then what is going to happen at the emergency room. But I do think that that is owed to them sometimes too. So if I am worried about appendicitis or something like that, I'm usually going to say it, meaning that the parents are usually expecting to get a certain workup when they go to the emergency room. And I've changed my spiel a little bit with this because I do realize that a kid could pass gas or something could happen or they have a bowel movement and wow, that doesn't look like they have appendicitis anymore at all when they come to see you guys. And so I usually say these are the things that I'm worried about, keeping in mind that your child may look different when this team of professionals assesses them and things may change.
I cannot tell you how much I appreciate that approach because you guys have that longitudinal relationship, right? And so they tend to trust you more than they tend to trust us. I mean, it varies, right? But for a big part, if another doctor says you need to go in and you need to be tested for appendicitis, but by the time they get here, they had that big old poop and now they feel all better and they're running around and look really good, then I don't have to put them through that process, but they're stuck back on the appendicitis word. And so I think I really appreciate when a doctor is like, this is what I'm thinking about, why it's important for you to go in, but please, I'm sending you into somebody else to be evaluated.
Yeah. Lena, I thought it was interesting, you mentioned insurance and obviously follow-up as an issue. And it feels like sometimes there are these non-medical reasons or non-medical things that are going to affect the triage. I think also about medical legal implications associated with the decision-making process. How do you navigate these legal considerations to ensure patient safety as well as appropriate care?
I don't know that I navigate them in the sense of I don't think about the legal considerations. My philosophy on legal anything is if I do the right thing as a doctor, that I'm probably within our legal restraints. So I think about it more as access and limitations to access and limitations of systems rather than, medically, legally, am I going to have a problem? I think if I'm not treating people appropriately, then yes, medically, legally, I'm going to have a problem. I got written up as a resident because I sent an undocumented person with chest pain in the emergency room for a chest pain workup. And I think that was a big lesson for me because I said I would send that person over and over and over again, whether they were documented or undocumented. And it ended up being a really great conversation between myself and the person that wrote me up because I went to that person and talked to them about it. And they said, well, based on my assessment of the patient, they didn't have concerning chest pain. I said, well, based on my assessment of the patient, they did. And so I just think that, we don't always have time to collect all the information around insurance status. We just see patients and we know the limitations of our systems and we just work accordingly and you do the right thing or what you think is the right thing, which realizing someone else might have a difference of opinion, that's what makes medicine both fun and frustrating at the same time.
Olivia, I really appreciate that you are still so optimistic about the legal system, medical legal system, that you have not had the experience of yourself or a colleague being sued despite doing the right thing. I know people who I would say they did the right thing also, and they are in a sticky wicket. So I do think that medical legal weighs on people's hearts and their minds, and it's so GD stressful to be sued that I think it's hard not to let it change the way that you do things and not to let it color the lenses that you're looking through as you make these decisions. Because I do think the reality is we are on the hook and we are trained, but we are making really, really big decisions. And there's probably less risk with saying, I told you to go to the emergency department then let me see you the next morning, right? Like you're never going to be sued for saying you should go see another doctor, you should go to the emergency department, but you might be sued for saying you don't have to go to the emergency department. And I think that does weigh on a lot of people's minds and hearts as they go through and make those decisions. At least that's what I feel when I see people being sent in for what, to me, that chest pain that is like, did you really send a 7-year-old into the emergency department with chest pain? You guys all know that this is not a heart attack.
Yeah, I will say that I thankfully, have not had to go through any of that being sued, but I will when I'm having those conversations or the thought of the emergency room does pop into my head and I have that shared decision-making conversation with a family and we opt for, waiting to see the specialist or waiting to see me the next day. My documentation of the return or ED precautions that I discussed with them is something I put time into versus like a viral URI, I say like return precautions discussed. And if it's abdominal pain or something, then I will write in the specific things I talked about with them to go to the ED for.
Yeah.
I think also this kind of goes back to, Olivia, what you were talking about in terms of knowing your patients well. And if it's a patient you don't know as well, sometimes that's a little stickier too. So I just had a patient yesterday that I triaged who was sent to the ER for asymptomatic hypertension, which we see a decent amount. And, his blood pressure was high, 200s over 100s. These are, not great numbers, but it probably had been that way for a long time. He had 0 symptoms to go with it, but he was seeing a brand new provider at an FQHC where they probably had 10 minutes to see him before their next patient. And I don't know what exactly their decision-making was, but for whatever reason, they felt like he needed to come to the ER to be evaluated. And I do think that medical legal probably plays into that a bit. Like, ooh, those numbers look bad. I don't have the time to fully assess this right now. I'm going to send this patient to the ER.
Let's go back to that discussion about barriers to coming into the emergency department. Maybe it is insurance or maybe it is another provider that is Monday morning quarterbacking like I have and said, why did you send them in, and giving you that feedback on that. How do you help those patients overcome some of those challenges, and how do you overcome those challenges yourself?
I never think about insurance, mainly when I'm making this decision. Initially, like, will insurance cover the visit, I guess is what I should say. I think families do in terms of like, have I met my deductible for this year? Things like that. Obviously, I get that. That can be a huge thing. So as you're talking about the shared decision making, you may be taking those kind of things into consideration with them. I will say that depending on the insurance, so when I am working at the federally qualified health center that I work at, that does pose constraints about how soon they can see a subspecialist, how long that referral is going to take, what imaging I have access to in the clinic, other resources in the clinic like we've talked about. And so I have had that kid who I've seen 3 times who's like 4 with a really bad headache that's waking her up at night. And I ordered a CT scan 2 weeks ago that is in referral limbo or was sent to a location that only sees adults. And I just throw my hands up and I say, go to the emergency room because I know it will get done finally. And like, I know that not the best care, but something needs to be done. It's reality, right? And so those are the types of decisions that I'm more faced with is like, the time to accessing what this patient needs. And what I think is an appropriate timeline versus one that I'm not comfortable with.
So for the people listening to this podcast, I will disclose that Sacramento County has some of the worst health outcomes in the state of California, and it's because of our dysfunctional insurance system. And so insurance is a big issue for our patients because their outcomes are poor. That being said, again, as a provider, I think knowing the limitations of the system is what drives decision making. But we also know that people with certain types of insurance don't get good care. So when I see a patient that I know in a system isn't getting good care, I have to really think about what I'm doing and is what I'm doing going to lead to this person getting the best care possible for them. And because access is such a big issue for our Medicaid patients, oftentimes that will drive more people to go to an emergency room for a non-urgent issue, because the wait time to see someone, I know rheumatology, the wait time was 8 months, like 8 months to see a rheumatologist if you have Medicaid, which is so difficult when somebody has been on steroids for 6 months and you're like, can we start a disease modifying agent, please? So it is, insurance plays into our decision making, but I don't think that it drives our decision making. I think we just need to know what the results of the limitations of our system are as a result of insurance.
So what you're saying is that you are practicing in the shadow between ideal and reality.
I think all of us do, right?
Yeah.
That's
we
the
all
lives
do.
that we live.
Yeah, absolutely.
So how do you guys ensure continuity of care for patients who are sent to the emergency department? Do you collaborate closely with the ED physicians to kind of give them the relevant information that they need and ensure a smooth transition? How does that work?
Well, I think that in healthcare, we've moved away from talking to people, right? But does that mean that we don't collaborate? No, that doesn't mean that we don't collaborate. We just collaborate via text message, essentially. Like, we send little snippets of information into the EMR ether, and we hope someone picks it up on the other side. I can tell you, like, I've seen patients where the primary care doctor sent them in to the emergency room for concerns of a stroke. The patient was triaged to the CCU, the cardiac intensive care unit, because they had maybe a history of coronary artery disease. And then I'm evaluating them for admission, and I'm like, nobody saw that it was for a stroke, and the patient has focal deficits and they need to go to neurology, right? And what happened was everyone's moving quickly and no one opened the primary care note to see that they had been sent for focal deficits for a concern of a stroke. So I think that the text messaging, I know in our system, we use a lot of EMR interfacing, which I think does save time because you're not sitting on a phone. But I think sometimes things can get missed with that mode of communication. And so I know for me, my standard practice when I send anyone to the emergency room is to then look the next day to see what happened, because sometimes they don't get the workup that I usually don't tell patients what to expect, but whatever happened in the emergency room wasn't what I expected. And then I will then order that workup as an outpatient, because we said, okay, well, their urgent need is not there. And so let me continue the workup. But I think that I work in the resident clinic as well, and I can tell you that a lot of that gets missed. So I think that transitions of care can be problematic, because there's not great, like, closed loop communication that oftentimes on the inpatient side you're getting because you're seeing people and interfacing directly with them.
I think Peds is pretty good at this.
You and I have spoken on the phone many times over the years.
Yeah, I still get on the phone. I guess maybe that's just because that's how I was trained. And I don't know exactly. There is a new referral order that you can put in that's referring the patient to the emergency room, and you would put in a little bit of clinical information. But I enjoy giving the story and talking through with, my colleagues and mentors, what I was worried about. And sometimes before I even send the patient, to just pick their brain and see if they think that it is appropriate. And then I love looking at the chart the next day to see what happened and if they were admitted, which is always I'm always like, oh, that was the right thing, or bingo, or if they were sent home and what the outcome was. I will say that another thing that happens from our standpoint that I think could be cleaned up a little bit is a lot of patients think they need to follow up after the emergency room with their primary care doctor. And sometimes that is good, right? Like a respiratory issue. And we do want to see them to make sure that, they need to stop using their albuterol or whatever. But a lot of times it was that ear infection. And I really don't want to see you back in my office in 1 to 2 days because I could use it to diagnose a new ear infection.
Yeah, that's a standard thing that we do. That is one of our medical legal protections that we do. I will say, I do think that conversation that you're talking about, Olivia, Lena, is like ideal, because I know that when Lena is sending a patient in, that there's probably a real reason. Like, she doesn't just send everybody in. I know that. I've been working with her for enough years. God, how many years now? What are we at? I don't know.
Like seven,
Anyways, seven years. So I know that, like, if she's sending a patient in, I'm going to sit down in the room and take a good history if I haven't spoken with her, because I know that there's probably something going on. My pretest probability for pathology is real there. And that conversation helps to kind of direct that a little bit faster. But on our side, right, now I have to step out of a trauma or step out of seeing, I'm running 11 rooms to 15, 16. How many are we at now? I mean, like, it depends, right? Like, you can be having 11 to 15 active patients at any given time, and to step out and have that conversation can be really time consuming as well. So I think the point of, like, a handoff, whether it's through EMR with a clear, like, I'm worried about focal deficits, this is what I'm thinking, or a conversation to make sure that we're on the same page and that we understand each other. I think that is definitely the best thing for that patient.
Yeah, and just to highlight a couple things. So one is, we're lucky that we have this built into our EMR right now. So if you don't have this is something to look into, which is that physicians within our health system can actually send an ED referral, which pops up as a message when that patient gets triaged. And as somebody who's been doing the triages, when we have 50 plus people in the waiting room, it is really helpful to have that information of why that patient was sent in, maybe a quick note about what you want done or what you expect to happen. Do you want this patient admitted? That is really helpful information for me. The other thing with that is that we also have this secure chat within Epic. So whether I get that information or not, I can message that patient's provider or their specialist and have a discussion about, why they're here. Hey, I just triaged this patient in the ER. I think they're probably going to be waiting several hours. What are some things you'd like me to get started? What do you think needs to happen with this patient? And that's been super helpful as well. And then I have also just started calling as well. So when it is a day shift during business hours, I will try to reach out to that patient's primary care doctor, especially if they're not in my system and I can't get to them through an Epic secure chat message. And I have found this to be so helpful and enlightening. And sometimes there's a completely different reason than what the patient is telling me that they're coming to the ER. And sometimes the doctor I speak to says, I actually told them not to go to the ER. I'm sorry they're there. I will deal with this. We'll talk to them tomorrow. So either way, it's been a very helpful interaction. So a plug for calling those primary care docs or those specialists that sent the patient in.
I also want to say, Sarah, I've been calling primary care doctors for years. That's been an integral part of my practice during work hours. And the other thing that I tell my residents is, let's give the benefit of the doubt to our colleagues, right? We have all been misinterpreted by a patient for whatever reasons. Maybe it was our fault for not communicating correctly. Maybe there were some cultural or language barriers, but we've all been in that spot where somebody misinterpreted what we said. If it doesn't add up, my default is to try to give the benefit of the doubt to my physician colleagues that they were probably trying to do the right thing, even though I'm like, fever, 1 hour, really?
Asymptomatic hypertension, really?
Yeah.
All right. Well, thank you guys so much for being with us here today. Any final thoughts? Anything we haven't covered?
No, we're so grateful for you guys and everything you do in emergency medicine for our patients and being a safety net, so to speak, for when we do run into those barriers for some of our patients. So just know when you are encountering some of those more frustrating workups, maybe there's nobody else to do it besides you. And you're going to provide a lot of relief for that patient and that primary care doc, even if it doesn't feel emergent to you at times.
There are standardized triage protocols, and most of them are not executed by physicians.
Barriers to care include insurance, access issues, family resources, the clinic resources, the physician resources, distance from the hospital, language, just to name a few.
Communication is key. Let's be open to hearing from our colleagues and to give a handoff back to them and give them the benefit of the doubt.
We are a safety net for those barriers. Maybe there's no one else to do it besides you. Well, I don't know about you, Sarah, but that podcast helped me answer my own questions as to whether there was just a recorded voice on the other side directing all patients to go to the emergency department. And I have a better appreciation for the challenges that we all face as we practice in that shadow between reality and ideal.
Thank you to our department for helping us practice there.
And thank you to OM Productions for practicing in the ideal.
So until next time, stay curious, stay inspired, and stay tuned.